Hi, my name is Alikhani. I am Dean and Professor at CTOR Academy, and I'd like to welcome you to another session of CTOR channel. As part of the Back to Clinic, I'd like to share with you a very interesting case. A few months ago, a patient was referred to CTOR Academy due to the severe open bite, pain in the TMJ, and significant amount of asymmetry. Patient reported that long time ago she had orthodontic surgery and orthodontics treatment to address the open bite, and it seems it's coming back. Upon intraoral exam, we noticed that the patient has class 2 molar and canine in the right side, class 3 molar and canine in the left side, significant shift of the mandible toward the right side where the midline discrepancy was more than 6 to 7 millimeters, and the open bite that was extended from 4 to 7 millimeter in different area. Patient demonstrated some sort of a class 3 relationship between the anterior teeth from the point of the incisal edges. When we're looking at the occlusal view, we notice that the upper and lower first premolar has been extracted during the previous treatment. Upper jaw demonstrate a little bit constriction, and the lower jaw and upper jaw have mild to moderate crowding. When looking at the pan demonstrated a slight root resorption that can be related to previous treatment. Upper and lower wisdom teeth in addition has been extracted, and both TMJ demonstrate some extent of remodeling. That can explain why the patient was demonstrating so much pain and discomfort. When we're looking at the CEF, we notice that the patient received some sort of a Lefort 1 orthodontic surgery treatment before, where you can see the surgical plate in the upper jaw, and some sort of a genioplasty where you can see this surgical plate in the lower jaw. The open bite was extended from the first molar to the first molar in the other side. Also, the facial harmony of the patient demonstrates some lip incompetence. How we can treat this patient? Of course, two general treatment plan comes to our mind. One is surgical treatment that patient, due to the experience that she had before, completely rejected that option. So the second option that left for us was orthodontics treatment. Is it possible to provide orthodontics treatment for such a patient with the history of orthodontic surgery and so much open bite and asymmetry? We decided to try. To address the constriction of the patient, we had two choices, either to use expander or sectional mechanic, where we can apply bilateral forces. To address the open bite, we decided anterior teeth are almost in a good position, so we didn't want to extrude them that much. But the posterior teeth could be intruded. So we could use free object design with the segmental mechanics and TAD to correct the vertical position of posterior segments. To address the asymmetry, we decided to use Neuro-Inmuno-Mechanotherapy technique, or NIM, and that I will spend a few sessions on NIM in future, that how we can utilize this technique. Just in general, remember that during the NIM, we deprogram the neurological muscular relationship and we reprogram a new muscular relationship between upper and lower jaw. And the most important part, retention. This patient requires very specific retainers to keep the result of the treatment. Let's see what was the outcome of our treatment. When we're looking at the intraoral pictures, we notice that actually in the right side and the left side, both molar and canine went to the class 1. The midline has been corrected. Asymmetry is not there anymore. When we're looking at the panorex, we don't see further remodeling of the condyles, and also there is no further root resorption. In confirmation of this, we notice patient does not report any pain or discomfort in the TMJ at all. When we're looking at the CEF, we notice the harmonic skeletal relationship has been addressed, the harmonic facial soft tissue relationship has been addressed, and patient does not demonstrate any open bite, whether skeletal or dental. There are few lessons that we can learn from this case. First, orthodontic surgeries are not as stable. They are prone to the same relapse as orthodontics treatment. It just takes longer time. So if you really want to study the stability of the orthokinetic surgery cases, you need to look 5, 6, 7 years. Which means that if you decided to treat a patient orthodontics or orthokinetic surgery, stability should not be one of the reasons that you select one over the other. Second, having a surgical plate does not add to the stability of the case. Doesn't matter how you precisely putting these surgical plates. Case can relapse. They are regardless. Third, having a surgical plates does not prevent you from providing a proper conservative orthodontics treatment. So even if the patient had orthokinetic surgery treatment before, you still can provide orthodontics treatment for these patients, especially if they really don't want to go to another orthokinetic surgery. The most important part was that the improvement in the TMJ function and the fact that the patient does not experience pain anymore. That tells you that there is a relationship between occlusion and the TMJ pains, against the common understanding that occlusion and TMJ are not related. Especially in open bite cases, correction of the open bite properly can significantly improve the sign and symptom of the TMJ problems. And the last important part, doesn't matter whether you are doing orthodontics treatment or orthokinetic surgery treatment, you need to provide proper retainers custom made for this patient and follow them for many, many years to make sure that the patients are stable. I hope you enjoyed this session of CTOR channel. If you have not subscribed to our channel, please go ahead and subscribe, and please don't forget to press the like button. Thank you so much.